So I'm going to talk a little bit about this is going to be very simple, to the point, and we live in a very, very unique time of medicine where these technologies that we see are able to treat these patients, and I'm just going to highlight the technologies that exist in the world of peripheral vascular intervention, namely patients that we treat with lower extremity blockages. Okay, how do we treat them? What should we do for these? And what are the surgical and non-surgical methods, or endovascular methods? So Dr. Mawad had talked about this very earlier. We actually had the exact same slide, ironically. I promise I didn't copy it, but nonetheless, this is really important, an important slide. This shows what survival on the Y curve and time, years, on the X-axis. And the bottom line is this: the more severe the disease for peripheral vascular disease, the lower the survival. And I tell this to my patients who come in with severe PAD, that you have a 50% chance of living 5 years. And that's the bottom line. That's the reality. And that hits them hard when you tell them that you need to quit smoking, you need to take your statins, you need to exercise, you need to live better. And most of them start crying because this is a fact, and they don't realize that. But this disease etiology is a chronic illness. You know, when they have multiple interventions, they ask, well, doc, you did the bypass and it didn't work, or whatever the case is. Well, this is not a cure. These diseases are chronic, like cancer. And we have to understand that. And that's because of their underlying pathology. So really simple. We talked about this ad nauseum: smoking cessation, regular exercise, diet, and of course pharmacological treatments. We know antiplatelet therapy, controlling risk factors. We talked about all that. What are the indications to interventions for peripheral vascular disease? Very simple. Lifestyle limiting claudication. Dr. Mawada talked about that. That's an indication. Number 2 is rest pain. That's pain in the legs when they're just laying around. And number 3 is non-healing wounds, otherwise critical limb ischemia. Those are the 3 indications for intervention, okay? So there's 2 types of interventions you can do. You can either do endovascular interventions or operative interventions, okay? So what are endovascular? Endovascular is where you poke in the groin, you inject some dye, you see what's going on, you pass through the lesion, and then you have a number of different things you can do for it, okay? So the first is angioplasty. So you can either use a plain balloon, and I'll show you that in a minute, or you can use a balloon that's coated with a drug. And the reason for the drug is this drug permeates into the wall of the blood vessel, and it prevents neointimal hyperplasia. It basically prevents, so taking a step back, animal models, if you want to study disease in a blood vessel, you'll take a balloon, put it in a blood vessel, and then you'll take the balloon down and you'll study that blood vessel. Over time, it's going to develop a stenosis, and the reason is scar tissue. It's basically neointimal hyperplasia. So this drug prevents this neointimal hyperplasia. So there's 2 different methods. So the first is, as you can see, you have a wire that goes through the lesion. You have a balloon, and the balloon basically squishes the plaque to the side. That's all it does. Creates a greater luminal channel to allow blood to flow through. That's it. Plain old balloon angioplasty, okay? The next one is the one which is coated with a drug, okay, drug-coated balloon. And there's many different drugs, but paclitaxel, you can see that there's the balloon, there's the drug that's coated with it. You insufflate the balloon, and this drug begins to permeate into the wall of the artery, preventing this scar formation from occurring. Wait about 60 seconds, take the balloon down, and that's it. Okay, and I'll show you where that comes into place in a sec. So that's angioplasty. The next is stent placement. What is a stent? A stent is basically a nitinol structure that keeps an artery open. Okay, that's all it is. And there's 2 types of stents. There's just a simple bare metal stent, which is made out of nitinol, which is an alloy of nickel, or it's a drug-eluting stent, which is, again, the drug is coated on the stent, similar to the balloon. So we show you the image again. So again, you pass through the lesion with a wire, and you deploy this stent. Pretty quickety split. It gives you the radial force necessary to keep that artery open. Blood begins to flow through. Next. The formation with the drug is very similar, but the stent itself is coated with the drug, and it again permeates into the inner wall, the medial layer specifically of the artery, and it allows for the endothelium to grow, but not to grow uncontrollably. Okay? Next is atherectomy. Okay? Basically, what atherectomy is, these are devices that can go in the blood vessel and debulk or break down the plaque and take it out. Okay? So let's show you, there's many different types, but the two that I'm showing here, one is laser atherectomy, which uses light energy to pulverize plaque, and the other one's directional atherectomy, where you can actually shave the inner lining of the plaque and take it out. Okay, so I'll show you what that looks like. So you can see there's a lesion, the wire can't get through. You bring this device, it's about 760 nanometers of light energy, and it's basically pulverizing its way through the artery. And as you keep going through, you finally get your wire through, and then you can go back to ballooning or whatever else, a stent or whatever else you wanted to put in place. The other one is this directional atherectomy. And I use both of these pretty commonly, but directional atherectomy is like an ice cream scoop on the end, and it has a little motor that reticulates, and it's just shaving the plaque from the inside, and this plaque gets contained within a container. And once the container is full, you remove the device, clean it, and use it again. Okay? So you can see how useful this is for these patients that have severe blockages. Okay, next. This is a technology I use on every single patient. It's called intravascular ultrasound. And the dogma normally of doing an angiogram is to give dye and watch the dye as it goes down and see the areas of blockage. I don't do that. I use this device. I might use a very little amount of dye just to kind of get an idea, but it's a catheter that has an ultrasound on the tip that allows me to see physically on the inside what is the degree of stenosis in real time. So this is one of our patients. You can kind of see as we pass, it literally takes 5 minutes to do. As you go pass through, and cardiology uses a lot, I know. You can see all that debris on the outside. That's all plaque. So you see the luminal channels in the middle. This is the arterial wall right here. This is open, and you can see all the plaque on the sides. Here's in a stent as we speak. So very, very real-time data to see exactly what's going on. Because remember, angiography is two-dimensional. It's two-dimensional. Okay, next. There are new devices that are coming out as we speak, which are being used. For instance, shockwave lithotripsy, kind of what the urologists use to take renal calculi out. It's a catheter that has a balloon associated with it, and you have shockwave energy that disseminates into the wall of the artery. And what it does is it controls the fracture of the plaque such that when you blow your balloon up, you have a controlled fracture of the plaque itself. So to avoid dissections or injury to the blood vessel. Another technology, which is just kind of in the early stages of commercial application, is the utilization of that directional atherectomy, which was that ice cream scoop concept, but with it is that intravascular ultrasound on the inside. So in this particular example, rather than blindly kind of cutting the artery on the inside where you think you may have plaque, you have a camera. So the camera, or the intravascular ultrasound on the bottom right, is showing you where the plaque is, and you can direct your atherectomy or your ice cream scooper directionally into the areas to actually shave off the plaque. So you get the idea. There's another technology. This is a front atherectomy Phoenix by Phillips. This is another novel concept where it's kind of like the Archimedes principle, where you have a kind of a corkscrew at the front that's reticulating, and all the plaque is basically being transgressed through the catheter out to the back end of the device. I mean, I don't know about you, but this stuff is really cool. And this really, really changes the way that we can treat these diseases. Let me go to traditional. So what can you do? Look at some of the results of these. So on the left, you can see a blockage of an artery. You can see that the artery is blocked. There's no flow to the foot. We're able to open it up through these devices, and you get flow to the foot, okay? Very simple. Similarly, you have a blockage here, but you can see the blockage in the middle before and then after. You can see it right here. There's a blockage in the middle, a lot of collaterals, and then obviously it's opened up. So for above knee interventions, when you look at the 12-month patency, so how many of these stay open after 1 year? So if you just do plain old balloon angioplasty, that's a balloon that you just blew up in the artery, you have about a 33% patency with nothing else. But when you start doing some of these other interventions, 70 to 80% patency in 1 year, that's pretty good. What about below the knee? What about blockages that are below the knee? Well, when you look at the data, very similarly, 12-month patency for just plain old balloon angioplasty versus drug-coated balloon, et cetera, it's about 60 to 70%, not bad. What about surgery? You know, after all, we got a lot of surgeons here. What about surgery? Is there a role for surgery? Well, let's look. So what are the options for us as surgeons for bypasses? Now, we can actually bypass from any part of the body to another part of the body. And what's the purpose? We're trying to bring blood flow from an area where the blood flow is good to an area where the blood flow is bad. So in the first picture on the left here, you could see that this is an aortobifem. We're taking blood flow from the aorta, bringing it to the femoral arteries, or in this case, we're bringing it from the femoral arteries way down to the popliteal artery, or in here, we're going left to right, or, you know, we could sew bypasses anywhere in the body. Okay, there's nothing to it, really. What's the patency? Well, when you look at the 12-month patency and 4-year patency rate, so let's look at 12 months. The first column here is with vein. So utilizing great saphenous vein above the knee patency is about 84% in 1 year. That's pretty good. Pretty comparable to the endovascular results. What about PTFE, which is a plastic, polytetrahydrofluoroethylene? It's a plastic graft. It's not bad. It's about 79%. And then cadaveric vein is a little lower. But still, all three, not bad after 12 months. What about after 4 years? Well, still not bad. When you're looking at about 50 to 70% patency for FEM above knee pop bypass grafts. Now, obviously, we want to use vein. All of our colleagues here, it's vein first. We'll use vein wherever we can find it. If we can't find it, then we have to look at alternatives. But obviously, we want the best patency, and so vein is the best. Of note, I will say something very important. We talked about primary patency earlier and secondary patency. Basically, primary patency means that if you did something and you never looked at it again, how many of those are still going to be open? Okay, that's primary patency. Secondary patency is if it shuts down and you have to open it back up again, what is the patency thereafter? Primary assisted patency means that what do you need to do to maintain it open? So if you monitor these grafts, especially a vein graft, many studies show that you can keep these open 90% in 10 years with good follow-up. That's why all of us guys here, we're really aggressive in monitoring our patients with surveillance ultrasounds to make sure that if they have any early signs of stenosis that we can intervene through an endovascular approach. Okay, so primary patency is as such, but primary assisted patency, even secondary patency, is much higher with good surveillance programs. What about below the knee? Not bad. Again, bypasses below the knee. You're looking at vein is obviously the best. Of course, that goes abysmal after 4 years. So I personally reserve surgery as a last-ditch effort when there's absolutely nothing I can do. I do endo first, second, third, fourth, and when I think there's nothing that can be done endo, I will still try to do endo, because for me, once you've kind of done the surgical stuff, in my opinion, you do burn some bridges. So I think this is kind of the mantra of today's time: is endovascular is really a safe, fast, and remember, this is not a remitting, relapsing disease, it's a chronic illness. So we're trying to buy these patients time. So this is an example, 37-year-old male, end-stage renal disease. You can see he has a blockage here. This patient underwent a bypass. You can see this is the anastomosis of a vein graft in the common femoral artery. We sewed it down distally. He has excellent blood flow now in his foot. This was done actually in my fellowship days. And in those days in Boston, they're pretty conservative. You know, yes, they would do endo, but surgery was still kind of the mainstay of treatment. I would never have treated that with a bypass today. It would have been endo all day long, even if he was 37 years old. I mean, this patient did great, but I'm just saying, there are other options. We used to always quote the basal data, which basically says that any endovascular treatment is recommended only for high-risk patients who we thought would be living projected survival less than 2 years. That's not true, in my opinion, today. Okay, that's not true, in my opinion. So the benefits of an endo-first approach are it's remarkably safe. It is remarkably safe. I personally do about 800 endo cases a year, me personally. And I got to tell you, most of my colleagues, they do a tremendous amount. I think the complication rates are probably about 1%, and it's very, very rare. An emergency operative bailout for an endo case, it's very rare. It's very, very rare. Endovascular reinterventions are as successful as an initial intervention. Repeat interventions allow for limb salvage, and in many cases just to prolong these patients indefinitely, and you preserve distal targets. So if you ever had to do an operative approach, then you still have that option. As vascular surgeons, we have that option in our arsenal to be able to do endo, and if it doesn't work, we can always do surgery. So at the end of the day, endo is a real technology, I should say, is a real testament to our profession and our discipline. Of note, the FDA did just release, this was in February, a notice on remember those drug-coated balloons and drug-eluting stents that I was mentioning, that those drug devices have now some data that's saying that the mortality increases after 2 years. So they've put a not a black box warning, but a warning letter to all the physicians who've had those types of procedures to keep close eye on them, and it's at the physician's discretion whether or not to use them in the future. And I think there's more data that needs to come out to see whether or not there's any truth to this. Maybe my colleagues can make any comment on that. All right, thank you very much. Any questions? Dr. AZ.
Quick question regarding this atherectomy device. I don't know if there's a lot of data out about which type of atherectomy device should be used, but what do you think in your practice, which device would you prefer?
So below the knee, I usually use laser atherectomy. For soft plaque, I'll use laser atherectomy. For hard calcified plaque, I'll use that directional atherectomy to really debulk this. And, in my experience, it works really, really, really well. I know Dr. Kasmers and I talked earlier. I don't think he doesn't do as much atherectomy. We were kind of talking about it, and everybody has their opinions, but I think in my practice, atherectomy has done a tremendous amount to help salvage so many limbs that we treat. Yes?
How has the new controversy with the DCBs changed your practice? Are you still using them?
I never really used them, me personally. I never really did. I don't know, Ron, do you use them? Yeah. Yeah. Yeah, if there's young patients that had just aggressive neointimal hyperplasia, like you balloon them and they come back 3 months later and they have such aggressive disease, then I would have. But it was really rare, maybe less than 5%. But the data, just so you all guys know, for the last, 7, 8 years, the data for drug-coated balloons and stents were amazing, until this new data came out.
I use them regularly still, even with these provisos. So I'm not sure that the mortality data is good data. And in my experience, it really does prevent recurrent disease. I think it's also, if I were in an outpatient lab, I don't think I'd use it.
Yeah, the costs are, right. It's not paid for anymore.
Hospital pays for it.
Right.
So that's where I do the majority of my work.
Mm-hmm.
What is the smallest caliber blood vessel you can open?
That's a really good question. And I know this because of IVUS. I personally will go into the arch of the foot. So generally 1.5 millimeters is what I'll go for. How about you guys? What do you do?
Yeah, we have 1.5 millimeter balloons on our shelf regularly and use them regularly.
How about you, Ron? I mean, I'll do a lot of pedal approach, so I'll even put sheaths, slender sheath, 4 or 5 slender in posterior tibial or anterior tibial artery. And in fact, I would say about a third of the work I do is through pedal approach going up, just because the plaque is a lot softer on the bottom side for task D lesions. It's easier to get through. Any other questions? Yes.
Do you routinely use embolic protection?
Yes, absolutely. So Dr. Coffey brings a very, very good question, and I can't stress this enough. We have all kinds of tools, but these tools can fail. Remember the device I was mentioning, that kind of ice cream cone device? That can distally embolize material below, and if it shuts off your tibial vessels, that's a problem. On every patient, I use a filter. It's a small little filter that sits in the popliteal artery, and so any debris that goes down gets caught in this filter, and I take the filter out, and I got to tell you, most of the reps that are in my facility are in the back there, and I show them every time, and 9 times out of 10, maybe more, 99% of the time, there's debris in that filter, even if it's microscopic, and I think it's essential to have that. I know that there's some people that don't use it, but I think you really need to. How about you? How about you, Ron? No, you don't use it? Do you use it?
I don't do that many atherectomies, and one of the reasons is early experience with horrible atheroembolism.
Yeah.
With the filter.
Even with the filter? Do you use?
I agree, Doctor. I use it 100% of the time.
Yeah. I mean, I can't stress. I mean, I take it out and I look at it. In fact, many times I can't even take the filter out of the sheath because it's so full of debris in my own experience.
What kind of filter do you use?
I use not the Nav 6, the other one, Spider. Yeah, Spider 5 or 6. There's a lot of technology. Hopefully next year when we're sitting here, we'll be able to share other technologies that we have. And limb salvage is a major, major issue. But like Dr. Kasmer said, it's only one part of the puzzle. You got a whole line of people with all kinds of experience with different aspects of peripheral vascular or vascular disease. The technology is just fantastic. It really, really is. Any other questions? Well, we want to thank you on my behalf and on behalf of Vascular Health Clinics and all the speakers for all of you coming here. I know it's late, and many of you have come from very far, and we appreciate it. You have evaluation forms. Can you please fill those and leave them at your table? You will get your CME credits accordingly through Michigan State University, so they kind of need that to be filled out. And if there's no other questions, thank you again.